Yeah, good on you. Excellent.
About a month. You'd think you'd find time in a month to read the whole chapter, wouldn't you?
Yeah, it's true. And it wasn't too long. And I have to say, it wasn't anywhere near as detailed as I was kind of hoping it would be, particularly with the sort of mechanism of action of pimabendin. Fellowship candidates, you're going to need to go a fair bit deeper on that. And really kind of establish the link between the physiology, the calcium movement in the cell, and the how pimabendin works, I think. But what I wanted to do today is obviously just talk about heart failure management, but try and make it pretty case specific. So as if you're in a prac exam and you're kind of being asked, you're being asked a question that's a little bit more practical, if we can. So where should we start? Does anyone want to tell me what heart failure is?
I'll kick it off. It's when the heart is unable to sustain cardiac output or function to its regular function.
Good, excellent. The two main types of heart failure?
Forward failure and backwards or congestive heart failure.
Good, exactly. So we can have decreased cardiac output or we can have congestive failure. It's rare that we've only got one or the other. So most of the diseases that we have cause congestion, but also have decreased output eventually. Okay, so a case comes in. What clinical signs are you expecting to see?
With both, or
what might you see with any form of heart failure?
Dyspnea.
Good.
Cyanosis in some cases. Exercise intolerance. Sometimes syncope or collapse.
Good.
If there's significant cardiomegaly, you might see coughing.
Yeah. Physical exam?
Probably a murmur. Maybe an arrhythmia.
Good, excellent. And in cats, there's another heart sound finding that is not an arrhythmia. Gallop, good, excellent. And thoracic auscultation?
Could be crackles.
Good. What about cats?
Could be muffled. Maybe.
Good. Yeah. Awesome. What else are you going to look at? I quizzed you about this with a patient this week, Josh. How are you going to assess for right-sided involvement?
Like jugular pulses.
Good.
Yeah, things like fluid waves in the abdomen.
Awesome.
Yeah.
That's pretty much it. So we've talked about all the signs of congestive heart failure. Are there any signs of forward failure that you would be able to pick up on physical?
Weak pulses.
Yeah, good. What might the mucous membranes look like if the heart's not pumping very well?
Maybe like muddy.
Yeah, muddy. So sometimes cyanose, but that's more congestive failure.
So your your shock perfusion parameters, like your 6 parameters. So your mucous membrane color might be pale. Your pore capillary refill time. Your pulse quality. Your mentation, they might be dull or weak.
Good.
And if they're in full cardiogenic shock, poor cool extremities or low body temperature.
Excellent. Yeah, perfect. It's always the critical care vet that picks that one.
Yeah.
But it's a really important thing to remember that so where the heart is the thing that dictates perfusion, essentially. So if we have forward failure, it is shock, essentially, that we're looking for. Has anyone ever seen a dog with cardiac disease with profound pallor? Pericardial effusion is probably the classic that I would say we see it in. For some reason, the mucous membranes of their gums aren't as severely affected as their tongue, as opposed to anemia. So I feel like you look at the tongue sometimes and you're like, this dog is not perfusing, like when they're panting and stuff. So that's anecdotal completely. I haven't seen it written anywhere, but I would look at the tongue colour. I sound like a traditional Chinese medicine practitioner. But look at the tongue. Okay, what are you going to do about diagnosing it? We were trying to diagnose whether they're in heart failure or not what the underlying disease is. Because what you need to know in an emergency is not what the underlying disease is whether there's congestive failure or forward failure, or both.
A-fast, T-fast.
Mm-hmm.
T-fast for pericardial effusion, and if you can, an LAAO ratio.
Great.
And A-fast looking for fluid, signs of right-sided. And I guess if you can do like B-lines and things like that, that would be nice too, but I find that really hard.
It's probably just because you haven't seen a good example. Keep looking. When you see it, you'll see it. You can't miss it. Cool. Whereabouts, if you're looking for wet lungs, where are you going to look on the chest?
Like the perihilar region?
So deep in the lungs, it's probably actually going to be easier to see it a little bit more ventrally.
Mm-hmm. I guess that makes sense gravity-wise.
Yeah, and it's also less lung. So whilst it doesn't look that dense on radiographs, it's actually just as edematous.
Okay.
So LAAO, there's one more thing on the A-fast that would be great. It's like kind of difficult to find.
Called a vena cava.
Good. Why?
Yeah.
Yeah.
Because you can see whether there's signs of fluid overload based on how much it's bouncing.
Good. Excellent. Yeah. So congestion or fluid overload.
Yeah.
Volume overload. Let's say volume overload, because fluid overload implies iatrogenic, and in this situation, volume overload is more appropriate.
Yeah.
Excellent.
Is that the collapsing index?
Sorry.
Is that the collapsing index that?
I don't actually know what the.
Yeah, I just heard people talk about it. The vena cava collapsing index is somewhat, but I haven't had a chance to look into it.
Yeah, Helen, do you know what that is? Sorry, she might be driving. So Helen's a critical care vet, and they use it often in this situation, presenting with a patient with heart failure or volume overload, whatever reason. And
yeah, that is. Oh, sorry, Anna.
You go.
No, I was waffling on and I realised I was on mute. Sorry. There is. Sorry, Anna. I didn't mean to interrupt you. There is a. There is. I don't know them off the top of my head, but there is established indexes. I know definitely in cats. I can send you a paper I have on it somewhere. Where there is established, you can measure it, and there is like published guidelines, if you like.
Right. It's a really good thing to just get used to looking at. When I asked Mariano, what's the normal ranges of cava diameter, he was like, oh no, you just eyeball it, which requires 20 years of experience. So it's not that helpful for any of us. But you can sometimes see not just caudal cava, like you sort of go, oh, that looks plump, but then you look at there's just a little bit of brightness in the abdomen or little scant bits of free fluid starting to appear, and that will just support your sort of diagnosis of early congestive heart failure. Good, so we've got A-fast, T-fast on our diagnostic list. What else are we going to do?
Thoracic radiographs.
Excellent. Good. What are we looking for?
Any kind of evidence of pulmonary edema.
Good.
Venous congestion in the pulmonary vasculature. You can get an idea of cardiomegaly as well
Mhm.
but I probably more rely on the echo.
Yep.
That.
Good. And
Needs
in
the
cats,
atrial enlargement and stuff as well, usually on big hearts on radiographs as well.
yeah. What about cats?
No, they're no.
About
Pleural effusion.
exactly. So looking for effusion, like fissure lines and things, more so in cats than dogs, but certainly in dogs as well. Remembering that the patient's presented with respiratory distress, so we're looking for respiratory disease. But why do cats get pleural effusion? It's a bit of a trick question. I don't know the answer to it.
Because they're cats.
Because
of the cats. I think that's probably the right answer.
Dave once gave some answer for that, but I can't remember what he said. Sorry.
Well, he likes a story as much as me. So.
Yeah, I feel like it was a bit of a story. Anyway.
So I have read I've read this, like I've looked for the answer to this, and nobody's really that clear. Where the cava empties into, where the caudal cava empties into the cranial cava or something, the anatomy is different from in dogs. And I've heard that that's the reason why they tend to get more caval leakage rather than like abdominal caval leakage. But then I've heard another theory that because cats tend to get biventricular failure at the same time, so they've got predominantly myocardial diseases, so they've got HCM and RCM and DCM that are impacting diastolic function and both sides of the heart fairly symmetrically. And apparently with biventricular failure, you're more likely to get a pleural effusion than pulmonary edema or abdominal effusion. So I don't really understand why, and I haven't seen a really good explanation, and I was hoping somebody else had found one. We'll leave it at that. Okay, so we've done echo, we've done RADS. What else?
Can I ask, sorry, would you, everybody who's good at doing AFAS and TFAS, do you still do thoracic radiographs in this situation?
If they're stable enough, yeah.
Can you get away without it? Like, because I want to learn how to do point of care ultrasound, and I was hoping that it would be good to avoid, you know, just to have improved positioning of a unwell patient if you can avoid the RADs, or do you think they're going to give you a lot more information if you do them well?
Well, such a good question, because I think we do it because it's traditional. So we're more confident making a call on a radiograph than we are on an ultrasound. So I can tell you for sure that there's fluid in an animal's lung, but I can't tell you distribution. So I can't tell you whether it's perihilar on a radiograph and therefore more consistent with pulmonary edema versus purely ventrally, which is more consistent with aspiration pneumonia or something like that. So there's definitely value in radiographs, but more and more we're in situations where the animals are too unstable to position for radiographs, and the radiographs are done 24, 48 hours down the track of treatment rather than like, because we've also got LAAO and the wetness in the lungs, it's pretty convincing.
And can I have a small point on that, just about non-cardiac patients. Sorry, I know it's a cardiac talk, but I think the point of care ultrasound is really superior in unstable patients, like your trauma patients or something. If you have a pneumothorax, there's no point in putting that patient through a thoracic radiograph and destabilizing it if, you know, it can just sit in sternal safely on the crash bench, pop the probe on, it's got a pneumo, you can tap it, wait till it's stable to take thoracic radiographs. So it's definitely got its benefit in other cases, even though, like Anna says, in cardiac cases, you probably want both.
Yeah, cool.
I find percussion of the chest is a good way of picking a decent pneumothorax. In fact, there's many a chest I've tapped just on the basis of symptomatology and the hypertympanic percussion.
So that's like the cable measurement, Jeff, though. It requires 20 years experience.
Sorry, missed that, Anne.
It's like the cable measurement. It requires 20 years of experience.
There could be some truth in that.
Yeah.
The other thing with jugular pulses, I used to tell the students that there are 3 scenarios in which a jugular pulse can occur. One is where the heart is not filling because it's too stiff for some reason. And then you can think of causes of that. Another is, oh dear, I think the 3. Another is the atrium contracting onto a closed AV valve, which is certain arrhythmias. And the third one, oh yeah, faulty right AV valve was the third one.
Yeah. So that's a really good point in that all of those result in congestion, but in different ways. So AV stenosis is really rare, but if you had a really young patient potentially, certainly could see that as an early sign. But then AV insufficiency certainly, and that stiffness, we sort of, when saying stiffness, you sort of think of myocardial stiffness, but pericardial disease, effusion or pericarditis could certainly cause that as well.
Or neoplasia.
Or neoplasia, absolutely, yeah. So there's the one thing we didn't talk about, sorry, with jugular pulses is a way to elicit them. Did anybody read that in the textbook? I just remembered it when I read it. I was like, yes, I'm going to do that.
I just remember it from uni. You like lift the liver, like you lift the belly like that, and then they puts more pressure on the system.
Yeah.
Hepatojugular reflex.
That's the one. Yeah.
I have to say I never do it because when you're lifting the liver, you're always at the other end of the dog. But you should definitely do it. It's a really good thing to do if you've got an assistant. Okay, so we've done RADS, echo, T-fast, A-fast. Oh, sorry, we've done RADS, T-fast, A-fast. And what else are we going to do?
SpO2 or blood gases.
Great, excellent.
Blood pressure.
Good, Max. Why? What are we looking for?
Forward failure.
Great, excellent. So that's one of our only measurements of forward failure, our objective measurements of forward failure. Excellent. Anything else?
You do blood testing as well. So just general CBC biochemistry, electrolytes.
Yeah.
Good to have a baseline, especially if you're going to start medicating this patient with diuretics. And I guess if you wanted to, you could, I mean, probably worthless, but you could do like a pro-BNP, particularly in cats. Yeah.
Good. I wouldn't say that's worthless, particularly in cats. These patients are presenting in respiratory distress, and just because we're in a cardiac talk, because you know the answer, you're like, oh, well, I know it's cardiac, but it's pretty rare.
Not.
Yeah.
I think we're lucky in that we're often kind of going forward with a specialist echo, that kind of stuff straight afterwards. But yeah, I think to help kind of make the decision, pro-BNP will be really helpful.
Yeah, completely agree. So they're all the things I had on my list for diagnosis. Okay, so let's go into heart failure management now that we've diagnosed our heart failure patient. Obviously, there's non-medical management. So if they've got pericardial effusion, pleural effusion, abdominal, require any centeses, we're not going to kind of cover that today. I really want to go into the medications that we're using. And I really want you guys to be conceptualizing, we're using this medication to decrease preload, or we're using this medication to decrease afterload. Given that forward failure or decreased perfusion is one of the problems with heart failure, why would we be decreasing afterload? What situations is that appropriate?
If you have congestion and it's affecting perfusion.
The congestion is venous system, and then there's all the capillary beds so there's no transfer of pressure from the venous system to the arterial system because the capillary beds separate them. So
sorry, I meant oxygenation, sorry. If you've got congestion and it's affecting oxygenation, then you need to decrease your preload.
Oh, definitely preload. Sorry, I asked about afterload.
Oh, sorry.
You're right. No, that's right. You were perfectly right for preload.
Decreasing afterload makes it easier for the heart to pump
Absolutely.
and circulate. That's pushing against less resistance.
Good, excellent. And in a situation of degenerative mitral valve disease, which is the most common form of heart failure I think we see, so we'll get increased cardiac output, and what other benefit would we get?
Better perfusion, generally.
Better perfusion. If you got increased cardiac output, yeah. Better perfusion.
Decreased congestion as well. Decreased congestion.
Yes. Why?
Because it has somewhere for the blood to go forward. It's going forward.
Yeah. Perfect. So you decrease afterload, you also decrease preload by stopping the by facilitating the flow. So if you think about, I wish I had my heart toy, sorry. If you think about the ventricle.
Do you want me to run and get it, Anna, from the medicine office?
Yeah, that'd be great actually. Do you mind? Thanks, Alex. Can everybody see Alex on their screen? Not right now, obviously. Yeah, good. Okay, excellent. So particularly with a leaky mitral valve, if you've got a left ventricle that's trying to generate a whole heap of pressure, so we've got decreased perfusion, the kidneys are saying, or the baroreceptors are saying, we need more output, and the heart's just pumping away as hard as it possibly can, generating a lot of pressure in the left ventricle. If you've got hypertension, so increased afterload, the pressure in that ventricle, when the aortic valve is open, they're at equilibrium. So the pressure in the ventricle is higher than it would be otherwise. So I'm going to explain that again, just because I don't think I did that very clearly. Great, excellent, Alex. Show me left ventricle. No, you don't need that part. That's fine. So left ventricle. Can you please point at the mitral valve for us? Excellent. Can you please point at the aortic outflow tract? Good. Probably from the inside, if you can.
Yeah. Like that way? I can't see it.
It's probably up under the mitral valve.
Yeah. Under there.
Good. Excellent. Okay, so there's two ways that blood can go out of the ventricle. So during systole, when the heart's already being told to work as hard as it possibly can, it's trying to generate as much pressure as it possibly can. So it's going to contract to its maximum force that it's capable of. When you've got the aortic valve open, the pressure in the left ventricle is at equilibrium with systemic circulation. So systolic blood pressure will equal left ventricular pressure. If you've got a mitral valve that doesn't seal and your left ventricle is squeezing as hard as it can and generating much higher pressure than it would otherwise, you're going to get more blood going back through that leaky mitral valve. Whereas if the path of least resistance, because if you drop the systolic blood pressure and the path of least resistance then becomes the path out to the aorta, you're going to get less regurgitant fraction. So in humans, they talk about ejection fraction, which is the blood through the aortic valve, and regurgitant fraction, which is the blood through the mitral valve. So more blood ejected, less blood regurgitated, which means that you're decreasing preload.
Makes sense.
Make sense?
Mm.
Good. Josh, does it make sense? Yeah. Thanks. So decreasing afterload is a really important factor, and we tend not to focus on it too much. And we tend not to do blood pressures and things as routine in our heart failure patients, but it's really, really important. If they're hypertensive, it's going to decrease their efficacy of our preload treatment. And if they're hypotensive, obviously we need to really help them with their systolic function and cardiac output and perfusion, because that furosemide is going to slam their kidneys if they're not perfusing well already. Okay, cool. So let's talk about medical management that decreases preload. What options do we have?
diuresis.
Yeah, pretty much. Yeah. There's one more that we don't use very often anymore, and I don't even know if it's actually available anymore. But when I started practicing, there was a cream that we put on the inside of the ear.
Oh, your nitroprusside.
Nitroglycerin, actually.
Nitroglycerin. Oh,
yeah. Nitroprussides we'll talk about in that later on as well. It's the infusion. It is actually still available. Good. Okay. So. So, what's the most common diuretic that we use?
Well, frusemide, the loop diuretic.
Good.
And then also the potassium sparing diuretic. Name doesn't come to me.
Let's say aldactone or spironolactone. Is that the one? Lovely. Excellent. Okay, loop diuretic. What does that mean?
Act on the loop of Henle.
Good. Excellent. And how effective, I mean, frusemide is obviously the most effective. That's why we use it as the first thing we reach for. But did anyone see the table of what increase in fractional excretion of sodium that frusemide can elicit? It was quite impressive.
Yeah, it was. I was so surprised. Spironolactone is so low as well.
So low. It's such a useless diuretic. I think we need to think of it more as a RAS disruptor than a diuretic. So it's not going to make a huge difference to fluid volume. It's definitely not going to get a patient out of a crisis if they have an effusion or edema, pulmonary edema, but may decrease fluid retention via its aldosterone inhibition. So what about thiazide? I've actually noticed Rita using this a little bit as an add-on to inpatients with refractory congestive heart failure. Where does that work?
Collecting tubule, I think, wasn't it?
Distal convoluted tubule, close enough. And then the spironolactone works in the collecting tubule. So the theory behind using multiple diuretics that work in different places, so any sodium that's still left, any sodium that was reabsorbed in the loop of Henle, so 25% stays in the urine, whereas the other 75% got reabsorbed. There's still a chance in the distal convoluted tubule, like as you move through the tubule, to load more sodium into it. So by using diuretics that kind of work in series, so loop diuretics and then a DCT diuretic and then a collecting tubule diuretic, you'll actually kind of limit the capacity to reabsorb sodium from the urine more if you stack the diuretics together. So thiazide on its own is pretty useless, but then when used in conjunction with frusemide, might just be the thing that gets a patient out of trouble. So let's talk about frusemide first. Well, in fact, we can talk about all diuretics. So what are the complications of diuretics in general?
Hypokalemia is one of them.
Excellent.
And pre-renal azotemia.
Good.
Or renal damage if they've already got like CKD or something.
Mm-hmm. Yeah, absolutely. So what causes that?
Reduced renal perfusion.
Exactly. Yeah. So what we're trying to do is decrease preload to the point that the heart is under less stress, but not to the point where we compromise perfusion. We've taken things too far if we're compromising perfusion. So let's talk about that a little bit more. How are you going to monitor furosemide therapy?
Resting respiratory rate.
Yeah, absolutely. So that's the effect on congestion.
And potassium and creatinine.
Good. Excellent. So they're the main things. So what Dick used to do at North Shore, which I've kind of adopted, which I've never really seen written anywhere, but essentially it's okay to have an elevated urea. It's not okay to have an elevated creatinine. And maintaining the electrolytes is really important, because what will happen if they become hypokalemic?
You won't get effective heart contractions.
Very good. So it absolutely impacts the contractility of the heart. And there's another neurohormonal problem.
More aldosterone.
Good, exactly. Yeah, it switches on RAS, as does hypoperfusion. So if we've taken things too far and got decreased perfusion to the kidneys and told the kidneys that there's not enough blood, it's gonna amplify fluid retention. So then what happens when you trigger fluid retention in the context of trying to decrease preload? They kind of cancel each other out a little bit, don't they? So we're really trying to walk that fine line between triggering RAS, which we know is detrimental in more ways than just its fluid retention, like it will cause increased blood pressure. It will also, particularly aldosterone, is responsible for a lot of cardiac remodeling and fibrosis of the myocardium, which will decrease both diastolic and systolic function. So we want to minimize that with furosemide therapy. So interestingly, in Edinger, in this chapter, it says that after 10 to 14 days of a consistent furosemide dose, the fluid retention effects that you've triggered are quite stabilized. So you're very unlikely after that point to go into sort of hypoperfusion injury or anything to the kidneys. If you've documented this dose of furosemide does this to the kidneys, then you can pretty safely keep them on that dose until they go into congestive heart failure again. So they essentially find themselves in a new equilibrium where there's decreased volume in the system, but there's still kind of fluid retention happening.
So it's less important to monitor your biochem and electrolytes after 10 to 14 days.
Exactly.
Just your clinical signs.
Exactly, yeah. So we typically, after they're discharged from hospital, we do one recheck. And if their electrolytes are normal and the creatinine's normal, we say, okay, on your way, come in if the respiratory rate goes up. Whereas if we have to do a furosemide dose adjustment because they've got mild azotemia or something, then we'll say, okay, come back again in another week's time and we'll check it again.
Cool.
Is that what everybody
Anna,
else
can
does?
you let me in on your phone? I'm just going to do the school run. I mean,
yeah,
I'm going to zoom in on my phone as well.
Yeah,
I'll be back.
Yeah,
thanks.
Sure. All right. So what about torsemide? Did you guys read about that? Can we get that in Australia? I don't think we can.
I saw Amy use it in Vsauce for one of my patients.
Oh, really?
I don't know where she get it. Yeah.
Interesting. Because I know Rita is, like everyone in the US is raving about it. So torsemide, for the people who haven't read Edinger, torsamide's another loop diuretic, works in the same way as furosemide does. But patients become refractory to furosemide over time, where they don't seem to with torsemide, so you don't have to crank the dose so much. And I think that might have some anti-aldosterone effect, so it might be kind of the way it's working seems to be more consistent with a cross between spironolactone and furosemide. But the cardiologists in the US are all raving about this medication. It's just not available in Australia from what I can see at this point. I think Rita would find a way if there was a way.
The last I remember reading about it was a fair while ago. It was equally potent with furosemide.
Yeah.
But
So
I didn't know about the other effects. I think so.
Yeah.
They've probably been discovered since.
I think so. I mean, they were doing studies on torsemide in dogs in like 96. So I don't know why it's taking so long for it to become kind of commonplace, but it looks like we're getting more and more data on it now. Okay, so we've got RAS activation, we've got hypokalemia. And what other electrolyte abnormality might we see with furosemide use?
Hyponatremia.
Good, excellent. What's the cause of that?
Because your body's like purposefully, it's purposefully causing renal sodium excretion, so that your free water follows it.
Yeah. So what if our sodium goes really low on our blood test? What hormonal activation is that? Not outside of RAS.
Your
hypoosmolality. Wait. Sorry, I'm wrong. What is massive hypovolemia going to cause hormonally?
ADH secretion.
ADH release.
Great, excellent. So theoretically with furosemide, you're losing sodium, but you're losing it with water. So if you're measuring it in the blood, the amount of sodium per litre is going to be the same. Whereas what happens when you cause huge amounts of decreased volume is ADH gets secreted, which makes you kind of override the furosemide and retain what? What does ADH make you retain?
Just water, really.
Free water, exactly. So you end up with hyponatremia. So if you're getting hyponatremia on your bloods, you've triggered a detrimental hormonal response with your use of furosemide by causing hypovolemia. You probably need to back off a little bit. Does anybody else have any questions about furosemide or diuretic usage?
Do you commonly see a dog with volume overload have mild hyponatremia? I was just thinking the more water retained in the body that causing a dilution hyponatremia. Is that a thing?
Yeah, it's a thing. Yeah, for sure. These patients wouldn't be hypervolemic. I think they'd be normovolemic or mildly hypovolemic. So you've caused hypovolemia with your excessive furosemide use. And then the ADH has corrected the volume a little bit. So they're probably normovolemic, but they started hypervolemic. And the furosemide caused a hypo, and then the ADH brought them back to normo, probably. Does that answer your question?
Yeah. I think that makes sense.
So what we're aiming for is to go from hypervolemic down to normovolemic with our furosemide. We don't want to go into hypovolemic. Because remember all of those pathophysiologic mechanisms that cause fluid retention with congestive heart failure, or with all heart failure, not just congestive. Sorry. Okay. So let's talk about medications that decrease afterload. Why? We talked about why they're important, but when are they not appropriate? When should you definitely not decrease afterload?
They're hypotensive?
Mm-hmm. Excellent. And what sort of diseases, like even if they are hypertensive, what sort of diseases is it not going to make a difference?
Sorry, I didn't get the question.
So what are there any diseases where even if a patient is hypertensive, where decreasing that hypertension is not going to improve their outcome, or it's not going to make a difference? Like, can you think of any diseases where no matter, I'm wording that really badly. Should I just tell you? Sorry. So for example, if you've got an aortic stenosis, what's treating hypertension going to do? It's not going to relieve the increased pressure in the left ventricle. And the other diseases are in diseases where there's diastolic dysfunction. So if the heart can't fill, decreasing afterload is not going to do anything because the heart's already kind of trying as hard as it can. It's just not filling well. So tachyarrhythmias and HCM or RCM would be examples of those. So the cardiac output, which is what we're trying to maximize by decreasing afterload, is, what's the calculation? Can anyone tell me?
It's like stroke volume and, oh God, sorry, let someone else answer that. I can't remember.
So it's by minute, so heart rate and stroke volume. So if we're trying to maximize output by decreasing afterload, we're actually trying to increase stroke volume. And if the heart can't fill, you can't have any effect on stroke volume, and therefore there's no point. Make sense? So diastolic dysfunction is the contraindication for decreasing afterload. Okay, so let's talk about nitroprusside that Bron mentioned before. What does it do?
Like systemic vasodilation everywhere.
Good, yeah. So it's a balanced vasodilator, which means it impacts the venous and arterial systems equally, as opposed to nitroglycerin, the ear one, which is a preferential venodilator. So it increases the capacity of the venous system just to decrease pressure in there. So nitroprusside is going to decrease the pressure in the venous system by its effect on the venous system, but it's also going to decrease afterload by decreasing blood pressure. What is annoying about nitroprusside?
Like a short-living effect.
Short-lived, absolutely. So they become refractory to it really quickly. So you've got to get furosemide working while you're using it. And it's also light sensitive, so administering it's a bit annoying. And also metabolized to cyanide, so limits how much you can use. Interesting fact. You should put that in trivia next year.
That's a great idea. I had no idea.
Yeah, I know, it's amazing. Okay, so that's nitroprusside. What about ACE inhibition? That's something we use really commonly in congestive heart failure, well, in dogs with heart disease. What impact does that have on afterload?
Decreases it by because you're blocking and, oh no, I was thinking, doesn't it decrease systemic vascular resistance by decreasing, the vascular constriction?
Yep, good. Angiotensin.
What was the drug again?
ACE inhibitors, benazepril and enalapril, the prils. That's exactly right. How effective is it?
Not very. I think it reduces it by like 5 or something like that, 5%.
Yeah. Do we use it in an acute congestive heart failure setting often?
No.
No. Why? If it decreases afterload, why not?
My guess would be it takes some time to work, but I don't know.
Yeah, it does take some time. Is there any risk in using it?
Causing
you
more
will.
acute kidney injury.
Yes, acute kidney injury. Why?
Because it restrict the afferent and dilate the afferent artery in the kidney and reduce the renal perfusion.
Excellent. So ACE inhibitors decrease renal perfusion in the context of when you're slamming a dog with frusemide and you're also decreasing renal perfusion, you can actually cut off blood supply to individual nephrons and those nephrons will die. So you can actually trigger acute renal failure by using ACE inhibitors in a dehydrated patient. And we are causing pretty profound dehydration. It's not a controlled, like, you know, they always end up dehydrated and then they kind of correct when we're treating congestive heart failure. So I usually start in a naive patient that hasn't had any heart meds. So if we're talking about degenerative mitral valve disease, I'll start my ACE inhibitor a week down the track when they're there for their recheck and I can document that the creatinine's normalised or it's safe to give them ACE inhibitors. Rita's not using ACE inhibitors anymore. It's interesting.
I was wanting to ask about that because of the valve where there was no proven benefit over pimabendin and diuresis alone. Like, when are you using it now?
I'm a little bit more traditional in that I tend to use it with pimabendin and frusemide in sort of long-term management because it makes really good theoretical sense. I'm definitely not, I think it's been disproven as a medication that will delay onset of congestive heart failure. So I'm not using it in preclinical heart disease of any form. And I'm not using it if we're using aggressive frusemide doses. But I think there's a place for it. There's no consensus, which is hard. And I usually defer to Rita. But I feel like if the owners aren't too overwhelmed with medications, I'll add it in just to be safe.
And Damon Leader, he said he's not using it unless there's systolic failure, but how would a general practitioner know just if you've got hypotension?
That's a really good point. If you're getting echoes done, you should be able to, you would have a report on systolic function. So what measurement do we use on an echo to reflect what the systolic function is?
Fractional shortening.
Good, that's one of them. Yeah. So typically in these dogs with volume overload, during diastole, they're really dilated. So we've got a big internal diameter measurement. And then what should happen is the more stretched the heart gets, the more forceful the contraction is. It's Starling's reflex. And it should empty completely. So our fractional shortening difference between diastole and systole should be huge in an overloaded patient. And what happens eventually is that myocardium gets remodeled, it gets fibrosis, it gets tired, the calcium cycling goes downhill, and we end up with this. So fractional shortening goes back to normal, which makes it hard to comment on systolic function. So when we're talking about systolic function, we want to be seeing a hyperdynamic left ventricle, so increased fractional shortening. So if I see a normal fractional shortening in an overloaded patient, I'm thinking, oh, that's inappropriate. But the main measurement I'm looking for is that systolic diameter.
Right.
So if that's overloaded, if that measurement is big at the end of systole, then I'm going to say there's systolic dysfunction in that patient.
Right. The ventricular the end of systole.
Ventricular diameter at end of systole,
right.
Exactly.
Right.
Yeah, so it's the difference between diastole and systole is a little bit more subjective just because it should be high, it should be abnormal, and the fact that it's then normal is abnormal. Max, does that make sense? Is that your experience too?
Yeah.
Okay, let's talk about pulmonary vasculature specifically. What medication decreases afterload in the pulmonary vasculature specifically?
Sildenafil.
Excellent. How?
It's a phosphodiesterase 5 or 4.
Good, excellent.
Inhibitor, and so what that does is causes vasodilation in the pulmonary vasculature because there's a higher amount of receptors in that area apart from the rest of the body. Excellent.
Good. So there's lots of studies to show benefit to sildenafil in decreasing pulmonary hypertension, which is right-sided afterload. What diseases are most commonly associated with increased pulmonary afterload? Pulmonary hypertension.
Bronchial disease.
Both right. Yeah, perfect. So most common that we see is actually left-sided congestive heart failure. So chronic pulmonary edema causes remodeling and pulmonary hypertension. And there's been some studies now to show that sildenafil use in dogs with chronic left-sided congestion will benefit their exercise ability, quality of life as graded by the owners, and I'm not sure longevity, but definite benefits to sildenafil use in chronic heart failure patients. And then obviously airway disease is the other one that we see really commonly. So ruling out heart disease, then we're left with kind of airway disease as a cause of pulmonary hypertension. And I'm really sorry. I'm just going to check my phone quickly. Oh, okay, it's all right. I just got a message from one of the other mummies saying, "Are you picking up my son today?" I was like, "No." Sorry. Where were we? Bronchial disease. So we won't talk about bronchial disease today. Where are we? We've got 5 minutes. Let's talk about pimabendin. Which what does pimabendin do with afterload?
My understanding is I think it kind of competes against afterload.
Sorry, say again.
Sorry, I know there's a lot of noise here. Doesn't it increase contractility? So it kind of more competes against afterload? I'm not sure.
Yeah.
How
what do you know about its phosphodiesterase inhibition?
Not much.
Not much. So yeah. It's a number 3 phosphodiesterase 3 inhibitor, which tends to be more both pulmonary and systemic circulation. So it does actually cause vasodilation, balanced vasodilation. So it will decrease afterload, but its primary effect, as you said, is actually what effect does it have?
Increasing myocardial contractility.
Yeah, which is called a positive
inotrope.
Excellent, very good. Okay, so how does it do that?
Is it improve relaxation?
It does, yeah. And it improves systole. It improves contraction and relaxation. How?
Calcium something?
Yes. Yeah. Tell me more.
That was it.
Well done. Excellent. Max?
It's I think it opened the calcium channel and let calcium get into the myocardium, and I think that's the reason why it got a sustained contraction during a cycle.
Good, excellent. So the movement of calcium into the cytosol is what creates sustained, consistent contraction in the myocardium. So systole, the movement of calcium out of the cytosol back into the sarcoplasmic reticulum, and the speed that happens is what dictates how well relaxation occurs. So pimobendan is a calcium sensitizer. Remember we talked about the tide of calcium, how amazing it was, the degree of calcium movement that goes in and out of the cell, cytoplasmic reticulum, cytosol, so many times a minute, and the efficiency of all those calcium transporters and stuff. So this is where pimobendan is amazing, in that it increases the heart's sensitivity to calcium. So less calcium needs to move to create both contraction of the same force or dilation of the same rate. So when you've still got normal calcium movement, normal calcium channel function, you're going to get increased contraction for the same amount of calcium and faster relaxation or more complete relaxation for the same amount of calcium. So it doesn't actually impact the calcium channels, but it does make the heart work more efficiently with less calcium movement, and therefore the calcium channels don't need to be quite as functional to maintain the same level of contraction. It's a really amazing drug.
That's so cool.
So cool.
Why do human doctors hate it?
Oh, it causes ventricular arrhythmias in humans.
Oh.
Yeah. So they've got good reason.
And we're just lucky that that doesn't happen in cats.
Really lucky. Yeah, absolutely. I don't know whether it's also the different types of heart diseases that humans tend to get, like obviously myocardial infarction is the most common. So they've got big sections of their myocardium which are just fibrous tissue. So they deal with, it's kind of like a DCM, it's kind of like a boxer cardiomyopathy sort of syndrome where the myocardium's not relaxing or contracting in big segments. So maybe pimobendan's not as required because it's not going to help calcium movement in whole chunks of the myocardium that are dead.
Yeah, okay, that makes sense.
So maybe it's not, maybe they haven't put as much research into it because it's not as required, I guess. Anyway, we better wrap up.
Thank you.
Any questions about pimobendan? Nope.
Thank you.
Thank you.
No worries.
Thank you.